Next up, we're going to have a very close friend of the Institute, Dr. Warren Hewitt. He's currently the HIV/AIDS coordinator for the Center for Substance Abuse Treatment, and previously he was a senior advisor to the Deputy Director for Demand Reduction in the White House Office of National Drug and Control Policy. And Warren's going to bring us some comments around the SAMHSA updates on HIV/AIDS and addiction.
How's everybody today? You're doing great.
Right.
See, I'm glad you're doing great. It's rough out here. It's a pleasure to be here. I actually am, one of the initiators. I was at the first meeting and spoke with a good friend of mine, Sandra McDonald. We sort of turned the place out talking about outreach because Sandra McDonald at the time was one of the preeminent folks working in the outreach world. She defined a lot of the things that Jeff codified later on and that became so much a part of practice. Now, my role today, I get to be, I'm representing Dr. Wesley Clark. However, as Wesley knows, I tend to speak my own mind and talk about the things I want to talk about. And so I'll talk about some of the things that he would have talked about, but I'll talk about some of the things that I want to talk about. Everybody's used this term national syndemic, and I used it too. And I want to give credit to, it's one of our grantees actually, who, by the way, did a lot of outreach work in New Haven with several grants that he had from us, and that's Merrill Singer. He really sort of put syndemics on the map with his book and with numerous articles that have defined and characterized how we approach this concept of syndemic. But I'm going to talk a little bit about that. But I want to talk about this paradigm shift that we're engaged in right now. I want to talk about the things that are driving that. And I want to talk about some of the things that we need to do in order to respond to it. 30 years. I put this picture in the left-hand corner because it reminds us all what happened in those early years. The people, the places, the things that have happened in 30 years of this epidemic are enormous. Change is an inevitable and constant dimension of our personal and professional lives. Even as we meet here today, a constellation of factors and events will change and redefine the fabric of our shared reality. Remember that. That's something that's driving all of what we're about today. A number of these changes are likely to redefine the course of the epidemic. Of course, the National HIV/AIDS Strategy, a syndemic perspective of the interaction of substance use and mental health disorders in HIV, the decline of the incidence of injection drug use, health reform and the Affordability Care Act, and of course the continuing fiscal crisis at federal, state, and local levels. The national strategy, we've already talked about what the goals are. I'm not going to talk about that. One of the other speakers did. The United States will become a place where new HIV infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstance, will have unfettered access to high-quality, life-extending care free from stigma and discrimination. Every person, I guess that's where the drug users are. Every person, I guess that's where the mentally ill are. We need to remember something that we have not remembered throughout the course of this epidemic, that it wasn't always just about the injecting drug user, it was about the drug user. And it wasn't about the drug user who, sort of casually used drugs from time to time. It was about the drug user who was co-occurring, who also suffered from a mental disorder. We need to remember that the place at the table has to be set for all. And that's part of the theme of what I'll talk about. We in SAMHSA are engaged in a transition of our own. Behavioral health has defined what we are about. Services to improve the health status and reduce health care and other costs to society. SAMHSA is charged with effectively targeting substance abuse and mental health services to the people most in need, and to translate research into areas more effectively and more rapidly into the general healthcare system. Continued improvement in the delivery and financing and prevention, treatment, and recovery support services provided a cost-effective opportunity to advance and protect this nation's health. And we identified a number of strategic initiatives: prevention, trauma and justice, military families, recovery support, and of course health reform, information technology, data and outcomes and quality, and public awareness and support. Illicit drug users are significantly more likely to be treated, in our view of the world, in emergency rooms or in urgent care systems compared to non-users. A lot of substance abusers show up in ERs for assorted medical complaints, but a lot of them come in with issues with their addiction and wanting to be seen and treated in those systems that are generally not able to treat them. In 2007, over 1.9 million visits to ERs were associated with drug misuse or abuse. Approximately 70% of the adults who received outpatient substance abuse treatment received it at a private doctor's office. Another 11% at emergency rooms and 26% in an outpatient mental health center. Integrated care creates a seamless engagement by patients and caregivers of the full range of physical, psychological, social, preventative, and therapeutic factors known to be effective and necessary for achieving optimal health through the span of life. Shifts the focus of the healthcare system toward the efficient, evidence-based practice, prevention, wellness, and patient-centered care, creating a more personalized, predictive, and participatory healthcare experience. In SAMHSA, one of the things that we are engaged in, as you saw from Dr. Achter's presentation, I think where he talked about PICSI, which is the program integration thing that CDC is doing around STDs, HIV, TB, and hepatitis. We too are engaged in our own de-siloizing. Adopting an integrated treatment approach does not guarantee necessarily a truly integrated system. Silos can exist between the various services, systems, and agencies and organizations that are part of a recovery-oriented system of care. A recovery-oriented system of care. When I first got started in this business, we talked about treatment. If they come, we will treat them. When we treat them, they will be better. The paradigm didn't work. We saw them come in, go out, come in, go out, come in, go out. We understood one thing, that after treatment, there's a process of recovery. What we can do to bolster that recovery is intrinsic to the success of that patient, that individual achieving a life with recovery. We learned something. We are a learning system. Maintaining linkages and communication between all services and systems is essential. And clearly, effective case management is key to ensuring that the silos do not develop and that the approach continues to be truly holistic. We're moving in that direction. Now, there's some barriers. We have some delivery system design issues, physical separation of services, fragmentation, communication. If we talk about medicine, social work, substance abuse treatment, we all speak different languages. We have to develop a common lexicon, an ability to communicate, an understanding of case management on the HIV side and case management on the substance abuse side and the mental health side may be very different. We can't afford to assume that everybody understands it with the same degree of comprehension. Language differences, financing, siloed payment and reporting systems, competition for scarce resources. As we move more and more into this period of austerity, I don't know if the austerity is the term, budget chaos might be a better one, we're going to find that we're going to need to do things more efficiently, to do things differently. and we will be competing for scarce resources. I imagine that if I looked at our grant giving opportunities over the decade since we've been doing this conference and looked at the number of applications in each year, we would probably see the greatest increases in applications in the last 2 or 3 years. More people are competing for the same thing. Now, the problem with that, as we learned, I think, in the CDC competition of 2 years ago, CDC competed for the community-based organizations for HIV prevention, risk reduction. The whole landscape of services changed. A lot of the people who had been doing the work didn't get funded. The reason they didn't get funded because they didn't get the best grant writers. And what we found out in our own experience at SAMHSA is that we had actually several grants in the past year who relinquished because there was a gap between writing and implementing. The people that hired the grant writer couldn't implement the grant. And we lost some dollars as a result. There are legal and regulatory issues, HIPAA and confidentiality rules, conflicting mandates at the federal, state, and local levels among the categorical programs. Anybody who's ever applied for a HRSA, CDC, or a SAMHSA grant knows we got a whole lot of different requirements. And they got a whole lot of different requirements. Why can't we have shared requirements? Why are we competing? Workforce, fear, loss of identity and priority, lack of cross-training. Now, we do have a concern about fear of identity loss. I mean, as the second, perhaps third-class citizens in the HIV community, you know, we get invited to the meetings, but it's, you know, sort of also starring, you know, that sort of third-rate actor that comes. We get in that same position. People see this epidemic in terms of MSMs, and they don't understand that it's a lot bigger than that. I'm going to show you some data that we collected on testing, and it's going to really make that point. But I'll tell you what I'm going to say later, now, because it's important. We looked at the data on testing. 2 things we found, 3 things. 1, we were seeing a lot more positives coming back in and being tested again. Previous positives that we were linking up to care. Good thing. Drug risk behaviors. Instead of seeing injection drug use associated with heroin and other injectables, we saw alcohol, marijuana, cocaine. Sexual risk behaviors. MSM was down there, heterosexual was down there, but having alcohol or drugs on board and having sex was the number 1. We got to understand, folks, the deal here is that I can look at the epidemiology of HIV in this country, and I'll guarantee you that if we interviewed everybody who had been infected or who might be infected and asked them if they'd like to have a little something, something before they do a little something, something, 99% of them will say yeah. So we got to understand that the pharmacology of these substances impacts behavior. So a lot of people that are sitting there saying, well, you know, I'm an MSM and I had sex with somebody barebacked and I got infected. Well, we know now from the methamphetamine literature that there was a little use going on. We need to understand that the intersection of HIV comes right through substance abuse. The second important dimension to this is you can be heterosexual or MSM, have no risk factors. But, you know, we all like to go, you know, on Friday nights, we go to happy hour. Now, why do we go to happy hour? Well, some people go to happy hour because you get that little hors d'oeuvre, little pig in a blanket or some shrimp or whatever. And we know the right ones to go to, right? I don't go over there because they get pigs in the blanket. I go here, they get shrimp. But that ain't why we go, right? We go there because it's a nice place to be, like the conviviality, right? And of course, I like to have my little Remy Martin or my little champagne or whatever. But you guess what? What am I there for? More often than not, I'm there to hook it up. And after 2 drinks, I'm not sure, but I may hook it up with anybody. So we got to understand that dynamic in terms of HIV infection, because it ain't over. Antiretrovirals get us right here, but behaviors still put us at risk. So that's, I've already discussed probably about a dozen slides. One of the speakers, the last speaker, talked about our targeted capacity expansion grants. Are actually called integrated behavioral health primary care networks. We funded 11 cooperative agreements, $42.6 million as part of the national strategy. Now, we didn't fund this to be part of the ECHEP per se. We don't want to do things the way we've been doing them. What we believed in doing this, in creating this grant program, was that we wanted to integrate substance abuse treatment, mental health treatment, and substance abuse prevention with HIV care. We weren't just concerned about positives, we were concerned also about those who were negative, who came in with these behavioral challenges. We recognized an important distinction between this concept, a lot of you've heard about it, test and treat. Now, I happen to believe test and treat is important, but I got a new paradigm for you. It's test, treat, and treat. See, an unstable, active using drug user, I can get them into antiretrovirals, but how long do you think they're going to stay? We have to be more efficient and more directed in our care. And part of that care is when we test them and they're positive and we confirm that, we want to stabilize them. If they're mentally ill and they're depressed, let's put them on combination therapy. They're going to get medication and talk therapy. Let's get them stabilized so they can be adherent, so they can be compliant, so that the duration of their care is successful for the outcomes that we have for everybody else. That's part of what we're trying to do with the 12 cities. And of course, DC is one of those 12 cities, APRA, and has the grant for that. We have 11 cities. One of them didn't make it. That's another story. I can't go into that. You know, they'd have to shoot me or something like that. I don't know. But we got 11 cities. We're optimistic about what we're going to be able to accomplish. We have an evaluation to follow them, so we're going to learn some good things. We also funded 26 supplemental grants to do testing. A lot of our minority AIDS programs had not been doing testing, and they didn't have the wherewithal to do that, so we're funding it on a one-time basis, and hopefully we'll continue it. By the way, if I run overtime, I've been told I can talk as long as I damn well please. And I intend to do that. You have to drag me from here. In 2009, the president signed the Consolidated Appropriations Act, which allowed us to use existing dollars to do syringe exchange. We call them syringe service programs. That was the agreed upon term. They didn't like needle and syringe, they didn't like a bunch of other things, but we agreed to do that. We have 11 grantees. We may have 9. I think that there was some change in fiscal year to fiscal year, but we're doing syringe exchange. The challenge, however, is that that was for 2011, 2012, with the budget being what it is, and the politics of this being what it is. A lot of you know that one of the House members, not introduced, I guess they were talking about, I don't know if they've introduced it yet, it was in committee about rescinding syringe exchange. Obviously, this was not a public health trained person. They would know otherwise, but it is what it is. We're hoping that saner minds will prevail and that syringe exchange will continue to be part of our HIV, our public health armamentarium. I want to talk about the magnitude of risk. 51.8% in 2010. 131 million people had any use. This is not the usual problem use. These are the happy hour folks. 131 million people that, you know, use a little, we all have a little drink now and then, right? And when you get that little warm feeling, do you feel different? We got to be concerned about this group. The binge drinkers, 59 million binge drinkers. population at risk. And then, of course, heavy use, 17 million people. This is just alcohol. We're not talking about illicit drugs yet. Now, this is one of Dr. Clark's favorite slides. 20.5 million people need treatment, but are not receiving it. Now, we got a bunch over here. 3.3% felt they needed treatment, did not make the effort. Lazy. I got a problem, but, my back hurts. I can't get up. I ain't got no job. A lot of reasons. 1.7 felt they needed treatment and did not make the effort. And did make the effort to get it. We've got to move that unmotivated group into motivation. How do we do that? Part of that has to do with what you do. Where the rubber meets the road is a critical dimension of what you do. And I'm sorry, our care systems are set up in such a way that very few people get to the rubber or the road. You guys do it. 95%, 19.5 million, felt they did not need treatment for a variety of reasons. A lot of it was they couldn't afford it. 38%. 30% were just not ready to stop. I like getting high. It's my life. I don't have a job, so I get high. How do I make my money? I steal it. Or that's of course after I've exploited all my relatives and stole everything they got. But a lot of people get high and work too. Let's not forget them. We see them on the job all the time. Everybody walked down, been in before the buildings became non-smoking, you go down the stairs, get a little, you smell something, say, I remember that smell. I used to do that back in the day. We see people doing that, go out to their car, you see it's not tinted, it's smoked. And then prescription drugs, a lot of people on the job, high. But these are the excuses. No transportation, had health coverage but did not go. Covered treatment but did not cover. Covered treatment but didn't cover what I wanted. A range of different issues. This is a changing paradigm. HIV is a pernicious disease that can be controlled by judicious and timely actions. Rapid HIV testing can identify the vectors of HIV infection and early in the disease cycle can reduce transmission of the virus to others and mitigate morbidities associated with the infection. Treatment with highly active antiretrovirals can postpone end-stage HIV infection, AIDS, and reduce the risk of paternal and sexual transmission of HIV. However, for some populations, these alone may not be sufficient to achieve the goals of the national strategy. Injection drug use has declined. 30 years of HIV injection drug use has been a major factor in transmission. However, based on data from Man Alive, the Alive study, the incidence of HIV infection has declined dramatically over the course of the 2-year decade of the study. A number of factors account for this. Successful opioid replacement programs, syringe service programs, and other HIV prevention and harm reduction efforts. This is a slide from a methadone program from a colleague that many of you know very well. He's the first director of CSAT, which was OTI, Dr. Benny Prim. This is from ARTC. And look at this. 40 to 60 years of age, 73% of his methadone patients are aging. We got an older population. People age out. This is the same population looking at it from hypertension, diabetes, hepatitis C, and HIV standpoint. These people are getting older. They have chronic illness. They have the same illnesses that many people in my age bracket suffer from. So what we're seeing is a declining prevalence of injection drug use. Are we seeing new injectors? Yeah, there are some new injectors, but not nearly the same kind of demand for injection drug use that we saw in the 70s and 80s. All of these factors come together to change not minimize, but change how it is that we allocate our resources and our priorities. The profile of syndemic risk. 23 million persons were classified with substance abuse or dependence. 20.5 million needed treatment. 4.4% of all adults in this country, an estimated 9.8 million adults 18 and older, had a serious mental illness. 4.1 million of them did not receive mental health services. These populations are at the greatest risk for transmitting and contracting HIV/AIDS. They are critical targets for testing and for behavioral health care treatment. As I said, alcohol is a mood-altering substance. The behaviors associated with unprotected sex, sex with multiple partners, increased risk of sexual assault, unintended pregnancies, or sexual transmitted diseases. Now, one of the critical aspects of what we do in the treatment world is that we treat the drug addict. Heretofore, however, our concern was, well, let's get him drug-free. Let's get her drug-free. Let's get them back into the system. And of course, we know that the stigmata associated with being a drug user, and if you're in the criminal justice system, the prospects of a job are less than highly probable. But let's get them off the drugs. So where do we spend the time on their sexual risk behaviors? And part of the challenge is that we're having to do two things, at least in treatment. It's important for us to have a strategy for them not only to become drug-free, but also to change their sexual relations. So some of the people said, went back to the same community I came from, they used to drug, and to the people I drugged with, and instead of drugging with them, I had sex with them. Well, the risk exposure was there. We have got to be much more enlightened about how we blend services to achieve the best outcomes for drug users. Many of these drug users are also co-occurring. They have drug and alcohol dependence, and they also had serious mental illness. Here we see the drug or alcohol dependence. The first bar, 25.2% with serious mental illness. Drug dependence alone, 11.9, 12%, and alcohol dependence, 19. Co-occurring disorders are common in the populations that we serve and care about. The magnitude of co-occurring disorders increase vulnerability to relapse and rehospitalization. What's very clear, those of you who deal with adolescents understand that if you have an adolescent onset mental disorder, the likelihood is you'll have recurrence throughout adulthood, that the trajectory of that young person's life will be inalterably changed because of a persistent mental illness, and the increasing severity will be a dominant feature of their lives. More psychotic episodes, inability to maintain finances, housing instability and homelessness, non-compliance with medications and treatment, increased vulnerability to HIV, sexually transmitted infections, as well as hepatitis. So we have a population of mentally ill people in this country who we are not addressing in a systematic fashion around HIV. We have a mental health system in this country that hasn't seen the necessity consistently to see this population at risk for HIV. We have to change that song. Okay, I've talked about that. I'm going to move on. And these are the slides that I talked about. And I've talked about them. I actually have the slides in a box by Saul Levin in the back. And everyone can have a copy when I finish. Okay. Changing paradigms, syndemics, and social determinants. For a number of Americans, the HIV/AIDS epidemic is one of several intersecting and synergistic health problems which complicate the implementation of the National HIV Strategy. Mental health and substance abuse disorders and HIV have syndemic relationships and are driven generally by unaddressed social determinants which profoundly affect both the extent and severity of the disease, as well as the strategies designed to address them. Now, what are syndemics? It's the concentration and deleterious interaction of two or more disease or other health conditions in a population, especially as a consequence of social conditions that promote clustering. A syndemic constitutes multiple contemporary threats to the health and well-being of many disadvantaged and marginalized populations, but are not concurrent epidemics in that they are not completely separable phenomena. Together, they constitute synergistic health problems that can significantly affect the overall disease burden and access to services. We may not have known it as syndemics, but we understand the interface among these various diseases. And I'm not even talking about the other primary and acute issues that these same populations face. And this is sort of my rendering of it. Substance abuse, mental health, STDs, HIV, the socio-environmental context, and the social determinants of health. Now, this is Dr. Prem's slide. And it's very graphic because it says something that we need to truly understand. What's going on upstream in terms of history, schools, jobs, income affects us downstream when we see unequal health access, unjust economic and environmental conditions, when we see unsafe living and work and poor social and community networks, when we see social and health inequity, social injustice and health inequities. Some of my research has been to examine, in some of my presentations I've talked about the role of residential segregation. The more and more that I see and read, the more I understand. When we start to talk about social determinants, it begins certainly for African Americans with a discussion of residential segregation and how the failure to address the 1964 civil rights statutes which prohibited residential segregation have so much shaped the context for HIV. The risk that we bear as a function of HIV and for substance abuse and HIV is driven in large measure by what we see in residentially segregated environments. Probably close to 80% of the African Americans in this country live in segregated urban environments where the access for services is different, where the access for medical care is different, where even for the more affluent of us, give you a case in point, Mitchellville. If you compare Mitchellville with Potomac here in Maryland, Mitchellville is a very affluent African American. In fact, I believe it's the highest per capita, has the highest per capita income for African Americans in any other jurisdiction in the United States. But when you look at its access to care, access to quality education compared to Potomac, you see a very different set of outcomes. We need to understand that dimension and how it affects risk. The Affordability Care Act is going to change the fabric of reality. My colleagues have talked about that. I won't belabor that. I want to get down to the sort of brass tacks. Change and adaptation demands a strategic response. And these are my words to you. A re-examination of the strengths that were the foundation of our organizational successes. A candid self-assessment of organizational weaknesses. An optimistic but honest examination of the opportunities that the organization can capitalize on in the near future. And finally, a frank examination of the external factors and changes that could threaten or place the organization at risk. What am I saying here? Y'all got to get engaged in a new paradigm. Y'all need to start by doing that sort of basic first step, strategic planning. This is nothing more than SWOT. SWOT, if you don't know what SWOT stands for, it's strengths, weaknesses, opportunities, threats. We've got to be strategic about the future. We've got to understand that the threats to outreach are compelling. Are you provided for in the Affordability Care Act? No. Can you transmute what you do into the broader healthcare system? Possibly. But who's going to do that for you? Outreach came into existence because of an experiment that was funded by NIDA. Barry Brown was the sort of NIDA resident scientist who got outreach started. They invested in a number of clinical research studies to develop the 4 distinct models at the time of outreach. That was the government. And here we are at a time when there is a metamorphosis required. The government's not there to sort of tell you what's the next step. You have to decide what the next step is. You have to engage in a process of rethink. You have to look outside, no, I'm sorry, you can't look outside the box. That's the typical approach. You gotta walk outside the box and walk around the box and begin to understand what the box is and figure out what the next box will look like. It's on you. It's a critical step. Success favors the prepared mind. You have to prepare your minds. You have to prepare your wills. You have to prepare your whole body for the transition that's coming. Thank you. And have safe sex. This is Dr. Prim's slide too. It's one of my favorite slides, you know. It sort of gets it over. It gets it all. So, yeah, you have any questions? Do I have time for questions? Okay. All right, who's got a question? Go to the mics.
We'll take 2 questions. Just use the mics.
You want me to stop them? So everybody's got no questions. Well, let me ask you a question. Did that help any? Yes. Okay. If I could be any more candid, they would probably fire me. But see, I got 39 years. So I can talk to them like this. I can say, you know, happy trails. I'll check you on the rebound. Just be prepared. That's all I got to say to you. You can do this. This is just another transition of all the transitions that we experience in life. Be strong. Thank you.